So thank you all for coming back. We're going to move on to our second hour, and that is the session on lab test utilization. We're pleased to have two excellent speakers with us, Michelle Sholzberg and Dan Barrio. Michelle, I think many of you know, is division head of hematology and oncology at St. Michael's Hospital and medical director of the coagulation lab at the same hospital. She's involved in the research institute as well, and is actually the director of the hematology oncology clinical research group. She co-directs the hematology immunology translational research team at the same institute. Michelle has a lot of experience with the whole area of lab test utilization, and has been involved in this for some time, and has been working with Dan and a team members of the Quality Council to work on some guidelines for hospitals across the city. So we're going to hear more from Michelle, please.
Thank you very much, Khosrow. It's a pleasure to be here today and to present some of our work. And it's also wonderful to present alongside my colleague, Dan. So I'm going to share my screen to get to my slides. Okay. So we're going to talk about lab test utilization. Here are some relevant conflict of interests of mine, which predominantly are intellectual in nature. And here are some potential conflicts of interest related to coagulation testing, and that I've received some funding from some pharmaceutical companies that make clotting factor concentrates. But most of my disclaimers are intellectual in nature. And here are Dan's, so I will mention them briefly for him. Again, he has lots of intellectual conflicts of interest potentially, and he doesn't have any financial. So we're going to go through a few successful examples of lab test utilizations initiatives, and then we will go through the results of a survey that many of you may have taken part in of University of Toronto lab physicians and scientists, and then we will discuss some future directions together. So I will start with our first example, which focuses on coagulation-based testing. So just to remind you all, the prothrombin time and the activated partial thromboplastin time, the PT and PTT, are tests that are static assays that give us a very narrow view into a patient's hemostatic capacity. And it sort of has a blind eye to many elements of hemostasis, and in fact, the most common disorders of hemostasis. And so as a reminder, what about the origin of these tests? So the PT is effective at determining the amount of warfarin that is present in steady state, and that is what it has been validated to measure. And the PTT historically has been designed to screen for inherited hemophilia amongst patients who are deemed high risk, i.e. family members of individuals who are affected, and then subsequently validated to monitor for unfractionated heparin therapy. But these tests, importantly, were never designed nor validated to screen for hemostatic defects in unselected patients. And despite this, these tests are in every single order set known to man and woman. So the ideal coagulation laboratory test would provide an accurate and reliable assessment of the patient's in vivo hemostatic capacity, and imagine if we could also comment on somebody's thrombotic risk. But the ability of these tests to comply with these requirements really must be questioned, and it's always important to understand what a test is originally designed to measure and what it has been validated to measure. And I know that I'm preaching to the choir in terms of audience, but this is something that is not top of mind amongst bedside clinicians for sure. And so a few years ago, we had an epiphany at St. Michael's Hospital, acknowledging that these two tests were all over every order set and order panel in our hospital, in inpatient and outpatient settings and emergency department settings. And this really leads to excessive, costly testing. These tests are both expensive with minimal benefit to patient. It might mislead care and even translate into harm. And so this is the snapshot view from 2014 to 2015. Imagine this is a while ago, and this is when this project started. So there were 200,000 tests for PT-PTT that were ordered, nearly 1 million milliliters of blood in that year, and nearly every time both tests were ordered. And so one of the hardest things, as we all know in lab test utilization, is speaking to appropriateness of testing. Really hard to determine what is appropriate and what is not appropriate, but I think that we can say that if both of these tests are ordered every single time, that is grossly inappropriate. But there's really a lack of awareness amongst many clinicians about what these two tests are ordering and that they're, are evaluating, and that they're in fact distinct. People like to talk about them as a group, and they say coag tests without really having a good understanding of what they mean. So we developed a quality improvement project called ENACT, which is enhancing appropriate use of coagulation tests. And we wanted to know if a multimodal quality improvement initiative could appropriately decrease the frequency of coagulation testing at our hospital. So this was a prospective quality improvement study. We identified 4 areas where these tests were ordered in high volume, and you will notice it's the entire hospital. But we decided to first target the emergency department, and that part of the overall project we called reducing unnecessary coagulation testing in the emergency department. And that's where test volumes were particularly high. And we also had an opportunity to piggyback on the emergency department moving to an electronic medical record system and ordering system. And so it was the right time for us to partner with this group. So we identified relevant stakeholders. We also uncoupled PT-PTT testing options. And so historically at St. Michael's, even if you wanted to order one separately, if a patient was an inpatient or evaluated in the emergency department, they were automatically coupled. And that was because many years ago, a patient would have a PTT or intended to have a PTT drawn to evaluate for their unfractionated heparin therapy. But unfortunately, the wrong test was ordered, the PT was ordered, and then, more than 4 hours elapsed. The nurse who's evaluating the patient in the middle of the night realized, oh, the wrong test was ordered. And because 4 hours had elapsed, they had to repoke the patient. And so a workaround to this was to couple these 2 tests. But unfortunately, that led to a lot of unintended excessive downstream testing. And so we uncoupled it centrally, these 2 tests. So now you can actually order them separately. And we revised emergency department order panels. We presented at their rounds. We created educational materials and prompts in various areas in the emergency department. Here's just a view of all of the stakeholders that we needed to engage with to make this happen. Lots of people, but a really critical step. So important to engage with everyone who's involved in both from the laboratory perspective and then also the bedside clinical perspective as well. And so in January of 2016, we reviewed these order panels in the emergency department. So just as a reminder, these emergency department order panels are essentially the equivalent of medical directives, whereby the nurse in triage would evaluate the patient, and based on their presenting symptom, they would start with this panel of blood work. And so there was a routine panel, an abdo panel, for example, when a patient presents with abdominal pain, and this included an automatic set of laboratory tests. And then there are many others as well. I've put stars here for all of the panels that included both the PT, PTT. It's all of them. And so we revised this and we removed almost all of them. It didn't mean that the physician couldn't order these tests. Of course they could, but they had to do so mindfully. It wouldn't be automatically included in almost all of these order panels. Here's a view of the educational materials that we developed. And so we talk about when to order the tests, but really most importantly, when not to order them. And so we developed a top 5. Also, these educational materials were tailored for specific audiences. So this one is very specific to the emergency department. So for example, here we're saying an active trauma patient. This is obviously not relevant to a medical ward patient. And so there we modified the educational material accordingly. So the primary outcome of our study was both the rate of PT and PTT testing, and it was expressed as a rate of test per patient seen in the emergency department per week. And the control was the rate of creatinine testing because there were no changes made to creatinine during the same study period. The balance measure, which was used to evaluate any signals of harm by the changes that were made, was major bleeding that we crudely defined as the rate of red cell transfusions, again, expressed red cell transfusions per patient per emergency department week. This is not uncommon in hemostasis literature to use red cell transfusions as a surrogate for bleeding. It's in fact the most well-accepted definition, but just acknowledging that it's limited, of course. And we analyzed this using a Poisson regression. And so here are our findings. And so you'll see that we have a baseline here that spanned well over a year. And so the blue line is PT and the orange line is PTT. The y-axis is weeks of emergency department visits. And then on the x-axis is weeks and the y-axis is the percentage of patients in the emergency department who had these tests done. And so you will see that just upwards of 40% of patients had these tests done concomitantly. And then here is the intervention where we made the change to the order panels. You don't have to be a statistician to see that there was an abrupt decline in both PT and PTT testing, really significant. And then over here, these are our additional measures. And so again, you'll see these two tests tracking in the middle, the light blue and the orange, that's the PT-PTT. The top line over here is creatinine, the dark blue line. There was no change over that study period. We also wanted to determine whether there was something very distinct about the patients over the study period. So perhaps we were just evaluating less sick patients during that time. It could have accounted for lower PT-PTT testing. And so the way that we evaluated acuity was the proportion of patients that were, the rate of patients that were admitted to hospital, which was the green line over here, which didn't change over time. So they didn't happen to be less sick as evaluated by admission rates. And again, also we looked at the rate of patients presenting to the emergency department by ambulance as another measure of medical acuity, and that also didn't change over time. Our balance measure here is red cell transfusion that was completely stable over the time period, including after our intervention. And so there was a 2.5-fold decrease in coagulation testing after a very simple process change. And this translated into 55,000 Canadian dollars saved per year with no obvious evidence of harm. And I can confirm that this has been maintained at this time. And again, there's no evidence of harm. It's really important. Process changes are really important because we're just making it easier for clinicians to do less. We should not have the expectations that clinicians are going to be experts in coagulation. So the guidance is important, but obviously having good stakeholder buy-in was critical. This is also obviously very difficult when you're working in an academic center where there's substantial house staff turnover with many competing demands in the busy emergency department. Of course, the limitations is single-centered, non-randomized, and we have a lack of patient-level data. And we did publish this in BMJ Quality, if anybody would like to read it. And so we thought that if a similar intervention was applied to order sets throughout the hospital, that could again lead to reduction in unnecessary testing pertaining to coagulation as well as costs. And so we are working on that. And now I will hand it over to Dan.
All right. Thank you so much, Michelle. This is where
Let me quickly introduce you, Dan. Dr. Barrio is the division head of biochemistry at Unity Health. I think well known to many of you, has been interested in the area of utilization for quite a long time, is actually a member of the Ontario Test Review and Utilization Committee, as well as a similar committee at the Canadian Society. Dan, please go ahead.
Oh, okay, thank you, Dr. Daly. That's great. And thanks, Michelle. So Michelle and I actually put our presentations together. So this is my attempt of smoothly transitioning into my talk. And we'll bounce back to Michelle closer to the end too. But the PTT project is a great example of a highly successful utilization initiative, and certainly one that could be spread to other hospitals in the GTA. So before I dive into more utilization examples, this being a workshop, what I really want to touch on are the slides where Michelle demonstrated how she and her team went about implementing successful change to PT and PTT ordering. So I don't think this is a subtle point. It takes a lot of work to implement these strategies. So there is a process or a methodology to implementing the most effective change with the highest level of success. One highly recommended framework to do this is called the model of improvement, shown here. It utilizes PDSA cycles, or plan, do, study, act cycles, to encourage multiple iterations of checking a project and adapting to the outcome data. So in an effort to reach the most successful improvement. This may seem excessive maybe to some, but I've seen changes that were implemented and it didn't go well, and it was because a process like this wasn't followed. Everyone's so busy. You have a list of projects on your to-do list. You just want to cross them off quick and move on. But if you don't stop and check to see if it was successful post-implementation, you really have no way of knowing if the change was truly an improvement or not. And sometimes you'll be surprised. So the model of improvement is shown here. I'll briefly run through it. It'll set me up for the example utilization projects that I want to show. In the first step, getting started, you want to identify a potential problem and assemble a team of key stakeholders. So for example, you notice that on a somewhat frequent basis, repeat hemoglobin A1Cs are occurring on patients within a few weeks from their last measurement. And this might seem wasteful to you, and you decide to dive a bit deeper. The team you would assemble for this situation might include lab, IT, and endocrinologists, or endo being your content matter experts, to help review the issue. You want to see, is it legit, or are these repeats wasteful? Step 2 and 3 would define the problem, understanding your system. This involves a deeper dive into your data and current setup to fully understand the problem at your institution. So where are these repeat A1Cs coming from? How frequently is it occurring? What physicians? How are the A1Cs being ordered? So it's a fixed order set, paper requisitions. What are the key drivers to inappropriate use? All of this information would be critical to designing the best solution going forward. And very importantly, you want to ask yourself early on, is this worth tackling? It's a question you definitely want to ask, because it does take up a lot of time and effort, and you want to make sure that the problems is not just sort of a one-off or a couple times a month. And then step 4 and 5 is designing and implementing a solution. So ideally, you want to create a solution that will be computerized, automated, requires very little hands-on attention. These systematically built solutions will be highly sustainable over time and are unaffected by new hires or personnel turnover. So nothing is worse than creating a utilization project that critically hinges on a single person. After a few months post-implementation, that's the time to check in, look at your data, your outcome data. Is it what you expected? Are the test volumes up? Are they down? Are they sideways? Get feedback from both labs and clinicians to see if there's anything that needs to be further improved. And if so, that's how you start your next PDSA cycle. So it doesn't really matter what project you plan to tackle. If you apply this basic framework to any initiative, you'll improve your chances for success. Michelle, do you mind just switching the next slide? Thank you. All right. So one of the most common questions I get is, where do I begin? How do I know what test to target? From my experience, very generally speaking, most of the people in the lab or clinicians in a specific division already have a pretty good idea of where the waste is occurring. Overutilization is fairly common. So simply starting with a face-to-face meeting with some lab staff or clinicians in a certain area and asking the question, where do you think the most inappropriate testing is occurring? What should we fix? And this sort of open dialogue or discussion, I love this approach because it's so simplistic. It engages issues that are at the forefront of people's minds. So this is the best place to start. You'll get the most buy-in, and therefore you'll have an easier road to a solution. But if that approach doesn't work, a great other place to start would be Choosing Wisely Canada. I'm showing here. There are over 400 recommendations provided by specialty groups themselves. So for example, endocrinology or internal medicine. So they are basically telling you they know what their problems are, and these are the top 5 or top 10 biggest issues they see in their area. So they're giving you a great clue to start. So you can simply start with a few of these recommendations. And if you want, you do a data pull from your lab to see, do any of these look like an inappropriate utilization problem? So do you see, say, massive ordering of folate? Do you see that your lab spends 30% of your lab budget on vitamin D alone? Is ESR and CRP ordered together constantly? So these would be nice starting points. And from there, you can identify meaningful projects to tackle. Can you change the slide, Michelle, please? All right, great, thank you. Okay, so back to some key examples. Here are a couple examples of successful projects we implemented at St. Michael's Hospital using this PDSA framework that we talked about. Thyroid reflex testing involving TSH, free T4, free T3, eliminating unnecessary hemoglobin A1C repeats. This involves a hard stop or a cancel in the laboratory information system on an order if repeated within 2 months from a previous result. And lastly, a reduction in unnecessary AST ordering by simply removing it from a hospital paper requisition. Next slide. For our thyroid reflex initiative, we created an order code in the laboratory information system. It's known as TSH with reflex. And when clinicians order this code, the sample will come to the lab and follow this algorithm shown on the left side here. Oh, am I lagging? Oh, maybe Michelle?
No, I think that I'm lagging. I just want to apologize to you for it taking a while for the slide to come up.
Oh, no problem, no problem. Thank you. I'm just glad I'm not lagging. Okay. So yeah, this project, we follow the algorithm on the left. The lab analyzers will first measure TSH and hold on to that sample. And if TSH was abnormal, either low or high, it would automatically add on free T4 without any manual handling or intervention by the lab staff. So a fully automated solution. And it follows the guidance set out by the American Thyroid Association and Choosing Wisely Canada, where working up a primary thyroid disorder should be a TSH-centered approach, meaning that if TSH is normal, you don't need the free T3 or free T4 testing. This first stage of the algorithm alone eliminates about 40% of all free T4 testing at St. Michael's Hospital. The lab automation system then will wait for the free T4 measurement, and only if the result comes back as normal will free T3 then automatically be added on and tested. Again, fully automated solution. So the rationale here is that you want free T3 testing to potentially identify a T3 toxicosis. This second stage of the algorithm eliminates about 47% of all free T3 testing at St. Mike's. Next slide. Okay, so another project idea that we had was to eliminate redundant hemoglobin A1C testing. We found out early on that about 7% of our hemoglobin A1C testing was being repeated within a 1 or 2 month time period from a previous value. So this was significant enough for us to look at, to tackle, because our A1C method requires manual handling by the lab staff. So it requires a manual pre-treatment step. And we can only load about 5 to 10 hemoglobin A1Cs on our instrument at one time. It's manual, it's a bit tedious, takes time, and there's reagent costs involved. So knowing the lifespan of the red blood cell being roughly 3 months, repeating the hemoglobin A1C within a month from a previous value wasn't going to provide a significant enough amount of time to pass for the old glycated hemoglobin to exit the circulation. So basically, at least 50% of your hemoglobin A1C you are measuring today was also around a month ago in the circulation when you previously tested the patient. From a patient perspective, the argument is that you really haven't given enough time to see the full effects of either their behavior modifications, so if you've asked them to change their diet or exercise, or you started new medications like metformin. Ultimately, you want to wait a bit longer to see the full effect on the hemoglobin A1C result. So we looked into why this was happening. We found, one of the root causes was that a number of patients were simply seeing 2 or 3 different physicians at St. Mike's, and each physician would order their own hemoglobin A1C on that patient, just standard protocol. So in collaboration with endocrinologists, we defined redundant hemoglobin A1C testing as testing within a 2-month interval from a previous result. And we implemented a hard stop cancellation rule in our laboratory information system. So this would automatically cancel an A1C if there was a previous result within the last 2 months, no user intervention, fully automated solution. So currently we are canceling about 145 redundant hemoglobin A1Cs each month, which is about 6% of our total volume. Next slide. Thank you. The last concept I want to highlight today, so we talked about a reflex, we talked about a hard stop, and this is a family medicine requisition change. So, this one is it's interesting because it's the power of simply removing tests from a lab requisition and order set. It doesn't need to be fancy. So in collaboration with family medicine, we revamped the St. Michael's family medicine lab requisition by removing the tests shown in the table here: AST, conjugated bilirubin, CK, amylase, for example, were all removed off the lab requisition, paper requisition. And at the bottom are control tests, being tests that we didn't touch. They were left on the requisition as is. Examples being ALT, total bilirubin, creatinine, etc. By removing these tests off the paper requisition, out of sight, out of mind, so to speak, we dropped our AST ordering by 51%, our conjugated bilirubin testing by 68%, CK by 32%, amylase by 61%, the list goes on. Meanwhile, when you look at the control tests, ALT, total bilirubin, creatinine, all these were roughly unchanged pre and post implementation of this new requisition. Oftentimes people will look at the AST to ALT ordering ratio as an indicator of utilization, shown on the right here. Our family medicine group was hovering around a 0.6 ratio with the old requisition. And once we removed AST, the AST to ALT ordering ratio dropped to 0.3, which is more in line with what we see in the literature in relation to proper utilization. So keep in mind that we didn't restrict AST in any way. We simply, it is still freely orderable. It just, like Michelle said, it needs to be more thoughtfully ordered. And it's not readily present on the paper requisition. So next slide. So I guess jump back to Michelle here.
Great, thank you. Thanks, Dan. So now I'm just going to present the results of our lab utilization survey. And so Dan and I are fortunate to co-chair a working group from the Quality Council that specifically focuses on lab utilization. So we just would like to acknowledge all of the hard work of our members, and this survey is one example of what we've been trying to do. So the purpose of this survey was to get a sense of people's perceptions, feelings, and attitudes regarding lab utilization work across hospitals within the GTA and the TASN network, with the goal of fostering collaboration, harmonization, and consistency of utilization approaches and tools across the city. But we really felt that it was important to just get a sense of what people's baseline thoughts were on lab utilization first. And so we hope that this will be enlightening for you all. It certainly was for us as well. So we put together an 11 question survey, and this was transmitted to everyone via SurveyMonkey. So the first question was, which LMP division do you work in? And so you will see here the breakdown, and the majority of respondents came from anatomical pathology, pathology, and microbiology, with sort of a smattering of individuals from other areas. We asked where the individual worked, and so here you see the breakdown. So we have fairly good representation across GTA hospitals, which was nice. So here we used a Likert scale to help us understand people's perceptions and feelings and attitudes. And so this scale ranges from strongly agree, agree, somewhat agree, etc., all the way to strongly disagree. And so the more blue representation indicates more agreement, and the more yellow goes to disagreement. And so the first question is, I believe that lab utilization work is important to the provision of best-in-class care. And so here you're seeing strongly agree, and then I apologize, sorry, the orange is agree. The second is, I believe lab utilization work can be clinically impactful and meaningful. Again, so the majority are indicating agreement. People also seem to believe that lab utilization work can improve patient outcomes. There was some agreement and a little bit of disagreement that lab utilization work was mainly focused on cost containment and recovery. And then mostly agreement regarding lab utilization being relevant to the individuals or the respondents' field of practice. We also asked the respondents, so I failed to mention that the total number of respondents was 38, and whether or not these individuals successfully engaged in lab utilization work, and 68% indicated that yes, they had. And then if yes, we asked them to indicate the types of projects that they've been involved in. And so here are some examples: iron B12 work, choosing wisely, decreasing appropriate GNS, review of the inappropriate ordering of urine CNS, so some good micro-related work, including COVID PCR testing, and then some biochemistry work here with liver enzymes, and some hematology work as well. And if the answer was no, that the individual had not engaged in lab utilization work, we asked why not. And these, I think, are really important for us to discuss, and we look forward to people's comments and questions pertaining to this. No institutional infrastructure being available was a fairly consistent response. No mechanism for funding, lack of interest from relevant stakeholders was really important. A few people said that it's not my responsibility. More indicated there was not enough time, and then one said no interest. And then here we asked, I would be interested in engaging with the U of T LMP Lab Utilization Working Group if their mandate was to harmonize activities, promote opportunities, and facilitate collaborations. And here it's a bit of a half and a half. So half of the respondents said yes, they would be happy to, and then there's another half that were either lukewarm or not interested. And if you've been engaged in lab utilization, what analytes have you addressed thus far? So sort of similar to the question 2 times ago, but here you can just sort of see a snapshot view. I really want to give a shout out to microbiology and biochemistry who've engaged in the most work thus far, at least from our respondents' perspective. There's also some work having been done in coagulation, so hematology, and then also some transfusion medicine work as well, which is great. What analytes and lab utilization do you think that we should address? And so here, respondents indicated unnecessary repetitive blood tests, those that are not that are ordered not on the basis of current evidence, coagulation tests, vitamins, those with high cost, those with potential for harm, markers of neuroinflammatory disorders, and then sort of a smattering of additional tests were mentioned. But some general comments were obtained that indicated that those that tend to be ordered for historic and or outdated reasons rather than evidence-based or guideline-based, and I think we can all agree with that comment. Unnecessary and repetitive tests, so that was really echoed again even in the comments. Those with high cost, potential for harm, and to prioritize those with interfering substances where classification error would occur. So those are the survey results, and thanks to the working group and also to all of the respondents. And now I will hand it back over to Dan.
Thank you, Michelle. So at this point, this being a workshop, we wanted to leave a little bit of room for question and answer or discussion, but some things to think about moving forward. As future directions, what would you like to see maybe at your own institution or across LMP at University of Toronto? How can we as a U of T community come together on utilization initiatives? So I look at BC and Alberta, and they're very centralized groups, and they can implement a change that reaches 26 hospitals or half the province. But maybe in Ontario, we're a little bit more siloed. And so, I worry maybe a lot of us are reinventing the wheel. We're all sort of starting from scratch, working on the same initiatives. And is there a way that we could come together? So would this be feasible? And if so, what support would we need, and what is the value in this? So.
Well, thank you, Dan, and thank you, Michelle, for 2 excellent presentations. Davor, Dr. Brink from UHN will be coordinating the QA session and questions. So Davor, please.
Yes, so the floor is open for discussion now. You can raise your hand, start speaking, writing in chat box. Take your pick. So Dan, let me just start off. You're talking about A1C, and I just want to make a comment, and so maybe we can start up a discussion on that topic. We tried actually the same thing at UHN a while back, but our main issue, and this can be an issue whenever you try to control your, how often you repeat a test, is the way your electronic health record system works. So for example, in our case, we couldn't set that up because for some reason, if you block the repeated orders, let's say every 2 months, you also block scheduled orders, which physicians often put in ahead of the time. And even though they put in the schedule order 6 months ahead, it was, if they did it on the same day they ordered the test, it blocks them because it thinks it's within 2 months. So the ability to set up such control measures, and we saw it for a large number of tests, they do depend on how your health record system works. And yet, if that system blocks you right from the start, you may have trouble implementing it, and down the road having less of an effect on how to control the, the testing volume in general for that particular test. So that was certainly, in our experience, a major block to successful implementation.
Absolutely. And there is a bit of creativity to this too, in that when we first started down this road, especially with the thyroid reflex, our lab IT guy, Drake, who's fantastic, kind of looked at us sideways because he's never done anything like this before, an automated reflex. He wasn't sure we could even do it. So yeah, there is a little bit of maybe creativity in even being able to get these done in LIS systems. So absolutely agree. And I bet there's a lot of them just don't have that functionality too. So that is a limitation.
Yeah. Okay, we have a question from Kunyang for Dan about the FT4 project. So do you allow FT3T4 and or 53 for those whose TSH status was already known and a follow-up is needed?
So for we allow unrestricted testing. I'll just jump right into it. For neurosurgery, endocrinology, and OB. Basically, neurosurgeon endocrine was for working up a centralized pituitary tumor. In terms of primary thyroid disorders, everyone goes through the thyroid reflex. Unless you are on levothyroxine therapy, then guidelines say you only follow the patient with TSH alone, and we have an option just to order TSH.
Okay, so the next comment and a question is for both Michelle and Dan. Great presentation. As we all know, Ministry of Health recently sent the data about the AST and CK testing to hospitals and asked to take initiatives to reduce the unnecessary testing. Is there a way to engage the ministry in more initiatives like this? Anybody, Dan or Michelle?
Sure. I think that's Shafkat who asked the very pertinent question. So thank you. The answer is yes, absolutely. I know that both Dan and I, as well as many others, engage directly with the Ministry of Health in a working group that is focused on utilization, and is absolutely an opportunity for us to further harmonize and standardize utilization activities across the province, for sure. And so that working group at the Ministry of Health is led by Rita Selby, Coagulation Director at Sunnybrook and at UHN. And COVID certainly derailed some of the activities pertaining to hematology, but I believe, and Dan can probably speak to this, that I think that the biochemistry team is still doing some work, but yes, there are definite opportunities.
Sorry, Michelle, you are muted.
Oh, did you hear what I said or no?
Just the last sentence was cut off in the middle. If you can repeat.
I'm sorry, I think there's a weird lag, I think, with my internet. I apologize. I was just indicating that there is a Ministry of Health working group called TRUC that focuses on lab test utilization. Some of the work has been put on hold a little bit because of COVID, at least pertaining to hematology, but I do think that it's getting ramped up again soon. But I believe that there's some biochemistry work that is still moving forward, and I was asking if Dan wanted to comment on that.
Yeah, absolutely. So it's becoming more and more, I think, at the forefront of the ministry's future plans and thought process. So there is the TRUC committee who, Paul Yip, who's here today, and Rita Selby are also on. And it does conclude a component where we can highlight potential utilization improvements or initiatives by test. And that's something we're sort of working on at the moment, but it's early stages.
Okay, so next comment comes from Paul. Excellent work, both Michelle and Dan. Could you comment on repeat orders at St. Michael's? Is it lack of access to previous results in the EMR, paper-based or non-interface, or difficult to navigate the EMR, or behavior of easier to reorder a test and look it up?
I can start. All of the above. At least at St. Mike's, we have a mix of both paper-based requisitions and electronic ordering, which can be tricky when putting in the orders and not knowing, what is already there. Navigating our Sorian, our EMR, is, the clinicians do say it's not the most user-friendly, and to look up old results takes a lot of time and effort. And when they're working in a very busy schedule where they're just have patients back to back to back and sometimes double booked with patients, it really becomes a hindrance to then try to stop and just take the time and look. So if our EMRs were built a bit smarter and easier or more user friendly, I think that would help.
We have a question from Lucia from SICKITS. How do you ensure long-term effectiveness of utilization initiatives? Do you have regular reports or dashboard monitoring or something like that to keep track?
It's a good question. Go ahead.
Yeah, sure. That's a really good question. Sustainability is critical, which I think is why the focus has been on changing processes as opposed to relying on change in behavior, because certainly in the QI literature that has been shown to be a less effective strategy, the latter. What I can speak to what we have done, at least for PT-PTT, is we've just done some periodic looks. I'm not aware, at least at St. Michael's, of any automatic reports, but that's a fantastic idea. And we do have Shafkat, who is our quality manager at St. Mike's, and Shafkat, maybe this is an opportunity that we could look towards doing some interval sort of reporting of projects and looking going forward. I think that's an excellent idea. I can speak just specifically to internal medicine wards. So I'm sure many of you are aware of Gemini, which is a large data set across many of the towns and hospitals that is now actually going to extend to additional Ontario hospitals. They do have a dashboard, and that obviously would be ideal, but does require some funding. But they do look at lab testing and obviously, a myriad of other clinical variables as well. But Dan and I previously met with them and identified that as a key group that we would love to collaborate with. But obviously, it just looks at one component of those who order tests and interface with the lab.
So then we have another comment for the entire group that considering that utilization is now a required standard by IQMH, what are some of the strategies other hospitals are taking? So I guess if anybody wants to contribute an idea, they can join and speak up. I think the survey already covered some of the suggested topics, but different hospitals might be in a different place on that list about tackling some of these projects at their own institution.
I think that the question, sorry, Deborah, just to jump in, I think that the question actually, it's a great question, and it really emphasizes the impetus for this working group, because we feel that it's so important for us to exchange our ideas and successes as well as our failures across hospitals. I think that if we've had successful initiatives, there's no need to reinvent the wheel, and really just transfer them to other hospitals. And so that's sort of part of the point of the work that we'd like to do is just to make it easier, and potentially also to gain additional traction with key stakeholders at hospitals. If we emphasize, well, you know, this worked very well at Sunnybrook, for example, why don't we try implementing that at this other hospital and that other hospital? Or, you know, I just use Sunnybrook as an example, but I think that is one opportunity to engage stakeholders potentially more effectively, and also to make things easier. Obviously acknowledging that infrastructure and IT support, which are key components to being able to launch a successful initiative, is variable at different institutions.
I think there was a website right then that the Quality Council was about to design related to utilization that might compile such projects, including the failed ones as well.
Yeah, absolutely. That's something that we were looking at. So that might be a nice way to put what everyone's working on, and even just how they went about it. And that might distinguish why, you know, maybe one site didn't show as much success as another, and how we could all adapt to improve.
Yeah, definitely. Also here, yeah, we are planning to include almost like a database of different studies across the GTA. I think the survey can help. Perhaps we need another survey to actually, or some sort of a request for proposals, request for a current list of current projects, and make that happen for sure. That would really, I think, help others also, perhaps promote the whole idea across the city.
Excellent. We have two more questions so far. From Benjamin, excellent presentation and congratulations on the success with your initiatives. The question is, do you have a multidisciplinary lab utilization committee that includes clinician representation?
Yeah, so we have at St. Mike's, I guess you could say we have two committees. So we had one more executive committee that included the VP of Labs, the Chief of Labs, the Administrative Director, as well as many of our physicians throughout the hospital. So that was one utilization committee we had established. And then we also had one that was, at the time, or for the last little while, it's been more informal, but it was a lab-related utilization committee that involved some of our clinicians, an endocrinologist, a hematologist. Sometimes we had a GI doc there, as well as Shafkat, who's here, our quality manager, and that was sort of a separate, maybe smaller working group that allowed us to just get a lot of the projects done that we would then present to that higher executive committee. But because IQMH is now making it much more of making it a requirement to be focusing on utilization projects, we are forming a more formalized laboratory multidiscipline lab utilization committee that will include clinicians and lab experts. Michelle, did you want to add anything, or?
No, I think it's really critical to engage effectively with the bedside clinicians. Without their support, projects will go nowhere. So I can give an example of a failure. So we did want to extend the PT-PTT project into the preoperative facility. I have been trying to get them to yank out PT-PTT out of their order set since 2014. It's a challenge, and it's and I've engaged with the stakeholders repeatedly, but there are certain very firm beliefs amongst certain groups. In this case, it's the surgeons and anesthesiologists. And those firm beliefs, very unfortunately, are supported by very niche guidelines that are not evidence-based that suggest PT-PTT testing, with the exception, of course, of some few guidelines and choosing wisely recommendations that argue against PT-PTT testing before low-risk procedures. But I actually believe that many high-risk procedures that a PT-PTT should not be done as well, and we have data to support this. We've done a large systematic review. There are certain tests that clinicians are almost married to, or anchored to, but it is a challenge for some to remove a test from an order panel if they don't have guidelines to protect them medical legally. So that actually has been the big barrier. So it doesn't always work. And obviously I'm mentioning a very complex scenario, but I think it's important to approach the clinicians with that lens, and that there are some potential medical legal implications that interfere with effective rollout of lab utilization initiatives.
Thank you, Michelle. That's an excellent observation, and certainly I've seen that in my own experience in a number of hospitals. We have a question from Rosemary from UHN. Funding can be a limiting factor for quality indicator initiatives. Any suggestions of how to secure financial support for these activities?
I can start again. That is, I think, something we all struggle with, absolutely. For a while, St. Michael's Hospital had some dedicated resources to that executive committee that I was speaking of, and they hired, I think it was at least a part-time project manager to help keep these projects on track. In the past, that went away, I think 2 or maybe 3 years ago, but since then we've all just kind of doing it on the side of our desk. So I don't have a great answer for the funding, how to secure. I mean, one way to do it, at least how it was done in the past, was you go all the way up to the top to, maybe VP of labs or higher, and try to get support for utilization, maybe hospital-wide, and show that it's not just about saving dollars, but it's about reducing harm to patients, improving education, and just better overall quality. And if you can gain that support, maybe that's one avenue for getting a project manager to kind of help keep these things going, or someone to do the data analysis or whatnot. Michelle, did you want
to? It's such a challenge. Any work that I've engaged in thus far has had zero funding associated with it. And we've therefore relied on funding to support other projects. That said, I have unsuccessfully applied for grants to support lab utilization work. So I would be frequently on the lookout for small grants, because I don't think it's very expensive to do this work, which is the upside. But of course, it always helps. I will sadly report, though, that I have yet to be successful in securing funding. But that's the name of the game.
Yeah, you almost reach the separate, organizations that can provide funding for such purposes. It would be hard to compete with some of the other projects inside the hospital. Okay, so we are out of time. And Dr. Adeli, I guess you want to announce the next step. You are muted.
Yeah, thank you, Davor. Well, I really want to thank Michelle and Dan for their excellent presentation. This is a really important topic. We have had actually a lot of experience at SickKids trying to look at, for over 10 years now, look at utilization. And actually a committee was formed here at SickKids years ago, led by clinicians, which is I think the best way to do this, rather than by the lab. And we made some inroads for vitamin D testing, for folate testing, and so on. And Lucia, over the last few years, has been working with that committee to try to look at other testing. Like, for example, we recently identified IGF-1, which is a very expensive test. It's quite heavily utilized by some areas without really proper justification. Anyway, so there's a lot of work that can be done in this area. And I think this is an excellent discussion to have across the city, across different hospitals. Thanks very much again. So we're going to close and then come back in 10-15 minutes. At 11:15, we're going to have our third and last session. Third, but not last, in the sense that this is also an important topic, critical values in different areas of lab medicine and pathology. And Dr. Elaine Go from Trillium and Dr. Felix Leong from Mount Sinai will be presenting. So please either stay on or come back. Thank you.